Hi, and welcome to the next ACMD Challenge seminar. This one on lymphedema. Lymphedema Uncovered is the name we've given this one. I'm Erol Harvey. I'm the CEO of ACMD. And I'd just like to start by acknowledging the traditional owners of the lands on which we all meet. For me, it's the Wurundjeri people of the Kulin Nation, and I want to pay my respects to elders past, present, and welcome all Aboriginal and Torres Strait Islanders who are joining us today. And we do have a bit of a national grouping today. We have speakers from Sydney and Adelaide, as well as from Melbourne, and I welcome you from wherever you're joining us. So some housekeeping matters just to get started with. We're very happy to take questions and answers. Please use the Q&A box, which you'll see on your Zoom buttons down the bottom. And at any time during the seminar, place your questions there. Sometimes we'll answer them as we go along, but we will have a Q&A session at the end after all the speakers have spoken. And so I'll invite you to hold on till then, for example, to have your question addressed. If you're listening to this remotely or as a recording, there's still a chance to get back to us. Drop us a link either on an email or some of the contact details you see at the end of the presentation, and we'd be very happy to talk with you more about this important topic. This webinar is recorded, so you can watch it later. And if you can, I'd love you to hang on for another couple of minutes after the webinar so that you can give us a little bit of feedback on the survey. From the listing of registrants, you can see that we are covering a reasonable range, yet again, of researchers, healthcare professionals, and others. And clearly a lot of people are very interested in this topic, lymphedema. Just very quickly, the ACMD Challenge program has been very generously supported in its pilot phase by the Australian Medtech Manufacturing Centre, which is an initiative of the Victorian state government. And our program is divided into 3 distinct steps. This is the first one, the seminar, where we set the scene for a much more focused workshop where participants will engage face-to-face, and we'll tackle a couple of the small focused issues of what is a very, very big topic. And then after that, we actually will follow up with the conversations that we've had from the workshops and other feedback, so that we end up with our engineers, clinicians, scientists, trying to have a look more closely in a research project at what we might do to address the issues of lymphedema. So I won't spend too long explaining what this is, because we have a very excellent speaker lineup, 4 very talented speakers. As I said, the question and answers will be afterwards, and I'll give you a little bit of background to ACMD. But our 4 speakers today are Associate Professor Liz Dylke. She is from the president of the ALA, the Australian Lymphology Association, and she'll tell us what lymphedema is, a bit of a background, and a bit of a run on the best practice and management techniques which are currently used. Then we have Debbie Geyer, who is the Vice President of Lymphoedema Association Australia, who bring us the perspective of the consumer side of lymphedema. Very pleased to have Professor Neil Piller from Flinders University joining us. Neil is the Director of the Lymphoedema Clinical Research Unit at Flinders Centre for Innovation in Cancer, and he'll speak to us about some of the technologies used in lymphedema treatment. And Associate Professor Ramin Shayan is a plastic surgeon. He's at St Vincent's Public and Private Hospital, and also St Vincent's Institute. And it was his suggestion that raised this as a potential topic. And he'll be talking to us about some of the later stages treatment, mainly surgical treatments, and some upcoming research in the field. So I don't want to use up too much more time. I looking forward very much to the conversation's just going, and I'll invite our first speaker, Liz, if you'd like to. There you are. Welcome. Thank you very much. And I'll hand it over to you, Liz.
Great. Thank you so much for this opportunity to speak about lymphedema today, my favorite topic to speak about. And as Erol said, I've been tasked with introducing you all to lymphedema, which is no mean feat in 10 minutes, but I will give it my best shot. So what is lymphedema? By definition, lymphedema occurs when there's an insufficiency of the lymphatic system to transport the fluid out of the tissues. Now, the lymphatic system is a very underappreciated system whose role is in part to move that fluid from the peripheries back into central circulation. And it does the majority of the work in this area. So to put it more simply, lymphedema results in a body region when the lymphatic system can't keep up with the fluid drainage requirements. But to put it even more simply, lymphedema is a swelling of a limb or an area of the body. It's an accumulation of excess extracellular fluid and protein in the tissues that is not being returned back to central circulation. Once lymphedema is established, it is considered a chronic and permanent condition at this point. There's many things that I find fascinating about lymphedema, but in particular, it is the way that it progresses, which is twofold. First of all, we can get an increase in the size of the region with lymphedema, but secondly, we can get a change in the tissue composition of the region that is swollen. So it moves from being a soft and fluid-filled and pitting swelling to a change in the tissue where we've got more fatty and fibrotic and almost woody-feeling tissues integrated into the tissues. At this stage, lymphedema is far more difficult to manage, and therefore early diagnosis and early management, when it's still more fluid-based, is the focus. Another fascinating thing about lymphedema is the variety of causes and presentations that encompass the term lymphedema. It's not simply one entity. Primary lymphedema is an umbrella term for a variety of systemic and non-systemic forms of lymphedema that are caused by congenital deformities to the lymphatic system. For people with primary lymphedema, the swelling may present at birth or much later in life, and it may be part of a bigger and more complicated condition. Secondary lymphedema is a more common form of lymphedema, and while it's most commonly associated with the treatment for breast cancer, it is possible after any trauma or disruption to the lymphatic system. Therefore, any surgery where there's removal of lymph nodes or radiotherapy to a region with lymph nodes associated with cancers such as prostate, melanoma, gynecological cancers, as well as injuries, blood clots, mosquito-borne infections, obesity, and certain medications can actually cause problems with drainage to certain lymph nodes or overwhelming of the lymphatic system with extracellular fluid. Now, these different forms of lymphedema can result in different presentations of lymphedema, including where the swelling develops. For someone particularly with secondary lymphedema, the swelling will develop where there's been a disruption to the lymphatic system. So depending on the underpinning cause of the lymphedema, we can see the swelling develop in the head and neck, in the arms, in the legs, in the trunk, in the breast, in the chest wall, or in the genitals. Lymphedema in each of these regions brings their own considerations, their own challenges, particularly in the areas of assessment, diagnosis, and management. So with this background information, the next logical question is, what's the size or the scope of this problem? But unfortunately, in our field, this isn't not actually an easy question for us to answer for a number of reasons. First, even for the most well-researched types of lymphedema, which include particularly breast cancer-related lymphedema, there's a lot of different ways in the literature and in clinical practice that lymphedema is defined. So Professor Piller is going to talk more about the diagnosis of lymphedema in a little while, but my PhD was focused on the assessment of lymphedema. And so as part of that background research that I needed to do for it, I went digging through the literature to see how we've defined breast cancer-related lymphedema through the literature. And the resulting table was more than 5 pages long, with often no overlap in the different criteria and the different tools that were used for saying when somebody does or does not have lymphedema. This obviously causes problems with us knowing in the literature who does and doesn't have lymphedema and changes the incidence. Secondly, particularly for our cancer-related lymphodemas, we're constantly seeing changes in the way that the cancer is treated. And some of these changes will result in a lower risk of developing lymphedema, such as some of the less extensive lymph node surgeries that we're seeing secondary or to the lymph nodes, Well, some of them will increase the risk of lymphedema, such as some of the newer forms of chemotherapy, which increase the volume of excess extracellular fluid. A lot of our other major challenges in understanding how many people have lymphedema in Australia is that it's almost certainly greatly underdiagnosed, particularly for those with primary or lower limb lymphedema. Because when it develops can be very hard to predict, even for those who have a very certain insult to the lymphatic system, like a surgery for cancer. We can say with confidence, though, that about at least 20% of women who undergo treatment for breast cancer who have an axillary lymph node dissection will develop lymphedema. And that incidence is likely higher after treatment for other cancers, particularly for our gynecological cancers. So how do we manage this very complicated and multifaceted condition? I think it's important that we recognize that currently a combination of treatments are most frequently used together. And particularly, it's important that we recognize the burden and the involvement of our patients in successful management for lymphedema, as they're going to be the ones doing this day-to-day treatment. Much of the treatment for lymphedema that we currently use focuses on that fluid-filled aspect of lymphedema, with some of the newer ones coming in now starting to address the other stages of lymphedema presentation. So treatment for lymphedema currently involves at least 4 or 5 different modalities. The first one is usually almost always education. And this is in part because most patients have never heard of lymphedema until they're given the diagnosis. But even more importantly, it's very poorly understood in the medical community. And so it's important that our patients can advocate for themselves when they're interacting with their doctors, GPs, surgeons. And so education about their condition, what it means and what it doesn't mean is really critical. Secondly, we focus on skin care to make sure that we're maintaining the integrity of the skin. This is because we're looking to reduce the likelihood of a skin infection called cellulitis. Cellulitis is one of the leading causes of preventable hospitalization in Australia. And it's this condition that has an awful and circular relationship with swelling, where increases in swelling increase the risk of cellulitis. And when you've developed cellulitis, you tend to get even greater increases in swelling. So breaking that cycle through not allowing the cellulitis to establish with good skincare or managing the swelling is very critical for our healthcare system and our patients' well-being. Thirdly, exercise is recommended for all people with lymphedema with a variety of aims, including to improve strength and mobility as well as quality of life. Significant amounts of research have gone into looking at lymphedema and exercise for those with arm lymphedema, but less research has been undertaken to understand how to best do exercise for people with lymphedema in other body regions. Fourthly, a specific form of massage known as manual lymphatic drainage is currently used as a part of treatment. Now, the evidence for its benefit in certain presentations of lymphedema is not strong, but patients often report that they experience quality of life improvements and sometimes mobility benefits from regular massage. This is another area where more research, particularly outside of the arm, is needed. Fifthly, and probably most importantly, is compression. This is the keystone to our management and may be applied to the areas that are swollen in lots of different ways that we'll talk about further in a moment. And finally, I just wanted to mention that there's a growing number of adjunct treatments that use technology to address the aspects of the lymphedema treatment, presentation, and progression. So the ALA was very proud in 2021 to release our position statement on the use of compression in the management of lymphedema. This is a great document that explains a lot of the breadth and types of forms of lymphedema, compression for the use of lymphedema and where to use it and when not to use it. But it also recognizes and highlights some of the gaps in our understanding of what best practice in compression management for lymphedema is. I think it's also important to highlight that there's a huge gap in funding for compression, particularly in Australia and New Zealand, leaving many patients out of pocket or unable to afford this really important form of treatment. And finally, some of these treatments I think will come up later, but I thought it was critical to mention that there's lots of innovations that are changing the way we think about managing lymphedema. Some of these focus on other aspects beyond the fluid-based swelling. And each of these treatments have some physiological rationale for their use, but often are lacking in sufficient evidence to know how to best use them, particularly in conjunction with all of the other treatments that are routinely offered to patients. So despite some of these gaps in the literature that we've noted, lymphedema is being increasingly researched, which is very exciting. And we're now having over 1,000 papers per year published on the topic. Interestingly, Australia and New Zealand punch way above our weight in this field, and we're undertaking at least about 3.5% of all lymphedema research, which is well above where we'd be expected for our population size. So the field is ripe for more research and more disruption. And however, there's absolutely more research that is needed across the board. We are developing an increasingly sophisticated understanding of the lymphatic system, as well as the pathophysiology of lymphedema. And these things should be feeding into our research on the assessment, diagnosis, and treatment of lymphedema. So just to finalize, as Erol mentioned, I'm the president of the Australasian Lymphology Association, and we are the peak professional body. And our vision is to ensure that patients in Australia have excellence in their healthcare. And we do this by supporting healthcare practitioners to undertake best practice in lymphedema management, while supporting research, advocacy, and education for lymphedema in Australia. I hope that's given you a brief overview and introduction to this very fascinating but complicated condition.
Liz, thanks so much. It's a huge field, and you did brilliantly in 10 minutes to give us an intro. But I'm going to hand over to Debbie Geyer, who's going to give us a bit of a perspective of lymphedema, but more from the consumer point of view. So, Debbie, over to you.
Thank you. So, my name's Debbie, and I think I bring the consumer's perspective here predominantly today. I'm 38 and I was diagnosed with lymphedema when I was 20. I have primary lymphedema, so it just suddenly developed, over a period of weeks, I think, really, in my right toes, foot, and leg. And later on in life, my dad found out that he had lymphedema as well, and then his mother developed lymphedema in her arm after breast cancer, and we since found out when I was studying in Germany that actually her cousin also had primary lymphedema. So clearly there's something going on in my genetics. And I guess through that, I happen to be a doctor as well. So general practice is my field, and I've obviously developed a special interest with lymphedema. And today I'm representing the Lymphoedema Association Australia, which is actually a consumer body. So it's an amalgamation of all the support groups around Australia. And that's the voice I'm bringing today. But I just declare that I also am a medical advisor for the organisation that Dr. Dylke works with, Australasian Lymphology Association. So there's a bit of crossover there. I thought I would try and represent this slide by just looking at what the impact is on the individual. And so if we look at all the physical things that are happening, I always think of this as quite a physical condition, really. And, if we look at where the swelling is, it's obviously going to affect people differently. But looking at, one of the biggest problems that people come to us talking about is issues fitting into clothes. And obviously if the lymphedema is in the feet, then finding shoes, for me, they're two different size shoes, but, other people, it may be that the swelling's higher up and they can't necessarily fit into jeans or pants. And if it's in their arms, whether they can fit into jackets and so forth. So definitely that brings about a lot of self-esteem when it comes to appearance and what things look like. And obviously, if we're wearing compression garments, what do those garments look like? What do those garments feel like? And looking also at whether in hot weather in Australia, obviously all over Australia, there's different areas and climates. And so, up north, people definitely struggle with the heat and humidity. And I think the other thing that we forget about is that lymphedema can actually be quite uncomfortable. And if you think about skin stretching, even just when someone sprains their ankle and the swelling that they experience and the discomfort related to that tightness, imagine that then all over the limb all the time. And so that, usually when it first starts can be really quite painful, but also later on, depending on what changes people are going through. So yeah, it does vary. And then obviously, as Dr. Dylke also mentioned, the health and infection risk is certainly a big thing that's on our mind all the time. If we look at the psychological aspects, again, impact upon relationships, there's a lot of frustration that comes with this condition, partly because of limited access to treatments and funding, a lot of those aspects, and obviously self-esteem I've mentioned a little bit here. For some people, there's a lot of fear or stress with the condition, fear of getting cellulitis and infections and needing to go to hospital or actually being life-threatening. But also for those people that come through a cancer journey, it's a constant reminder of the treatment in the cancer process that they had, and that it's a constant fear if the swelling increases. Is it that the cancer's come back and blocked the lymph nodes? Is there something else that's happening here? So it's definitely always playing on people's minds. The social impact, again, relationships, spontaneity tends to be taken away. If you've got to plan for your trips, make sure that you've got all your equipment and your garments and so forth. Certainly as a young woman, going to the beach was never easy with garments and sand everywhere and all those things. It definitely required a lot of preparation. Same thing with travel. Time is another big factor. You know, if someone's doing bandaging, for example, all those things do take time. Some patients learn to bandage themselves at home or apply their garments. The garments need regular washing. They need regular changing over every 6 months. There's lots of appointments involved, very time consuming. And then there's the financial aspect. So, you know, I think when you've got to spend lots of money on garments or shoes, clothing that are different, and also that time away from work is obviously costly. Just a little something to just kind of give a bit of an idea, was something that we very strongly believe for the Lymphoedema Association Australia. Receiving a diagnosis of a condition you hadn't previously heard of or knew anything about is overwhelming, scary, and deeply isolating. On top of this, when the road to that diagnosis is unclear, uncertain, and long, the experience can be traumatic. Unraveling the options for ongoing treatment for a lifelong condition can lead to dead ends, detours, and bumpy roads. And while this is a common experience for many people living with lymphedema, it doesn't have to be. And this is very much so the sentiment within the lymphedema community. And so as part of this, to brainstorm what things we can try change. And I think that's why it's a really powerful thing we're doing here, to say, even if we can just touch on one of these areas and improve the quality of life for people living with lymphedema. And this is just something that, when we've talked to patients over the years, these are sort of the areas that come up, and this is by no means telling people what direction to go in, but just some ideas of where to think about. And so with diagnosis, again, as Liz has spoken to already, you know, there's lots of different things we look at. Finding out a bit about bioimpedance, it can be used in early detection, but also in monitoring stability. ICG fluoroscopy, worth finding out a bit more about, an interesting area as well from the anatomy point of view and diagnostics, but even understanding massage, you know, how much of that works as well. There really is a very limited knowledge within the health profession. So that's trying to get doctors a little bit more involved in that diagnosis is certainly, so finding how to crack that one. Looking at the treatment side of things, all our treatments, as you can see, are very physical. So for the therapists and the patients, labour and time intense. They're quite physical when you've got to do a lot of wrapping of a heavy swollen limb. The garments, there's issues when it comes to funding, you know, the consistency of actually prescribing. How do you know that just because one person measures you and then the different person measures you, you're going to end up with the same product? The heat and the comfort of wearing garments, and also actually here the infection risk as well if you've got the same one using over and over again. And those treatments are really costly. In terms of technology examples, Liz certainly touched on these a little bit, but I kind of break it into what's sort of positive pressure, so things that have compression on them, and looking at pumps and garments and wraps, as well as negative pressure, which lifts the surface of the skin. So suction devices like the physio touch or kinesio taping that lift, which, you know, we see all the time used in scar management in plastic surgery. And then also there's low level laser, which is also something that can be useful. Funding, one of the biggest things that Liz touched on is our limitation with statistics. We really just don't have enough information when we go to lobby to government. And in terms of patient compliance, obviously some of the things we've mentioned about already, if it's not going to be something that's comfortable or something that's possible for us to wear, then we're not going to wear it. And lastly, that infection risk. So looking at the skin and the skin care, how we can optimize that, and the cellulitis. these are sort of the organisations that are around in terms of training. So I'm New South Wales based, which is why Hetty there, they have a lovely module. In terms of treatment, going to the ALA where Liz, Dr. Liz Dylke is representing the National Lymphoedema Practitioners Register if you need to find someone who's qualified. Looking at support, that's where our organisation comes into it, and a lot of the Cancer Council groups. And then when we're looking at lobbying and advocacy, again, all of these groups tend to come together, and the breast cancer groups have been fantastic in their support too. And yeah, that's me in a wrap, I guess.
Phew, Debbie. That was amazing. Thank you so much. There's so many thought starters in there for the research community and technologists to have a think about, which leads very nicely on to our next speaker. Delighted to have Professor Neil Piller join us. Neil has been a clinician and a researcher in devices and technology in this area for a long time. It really didn't take long in asking around the community in Australia for everybody to be pointing a finger at Neil. And Neil, we're so pleased that you're able to give us a bit of a rundown on some of the technological aspects which are looked at for diagnosis and treatment of lymphedema. So over to you.
Okay, thank you very much, Erol, and thanks so much, Liz and Debbie, for setting the context of what I'm about to talk about. Okay, so what I want to have a look at today is current and previous technology for measuring edema, lymphoedemas, and other swellings. And I emphasize it's more than just lymphoedemas, for instance, chronic edemas and lipidemas and the like. So it's got a broader perspective than what we might be looking at today. So the most important thing is that our lymphatic territories, our body's divided up into a whole pile of lymphatic territories, but none of them look like these diagrams we see. And that's why we have to look at more than one side of the body for any given intervention or any given presentation. The lymphatic system, for that reason, is very hard to study and very difficult to deal with, but we've got an opportunity to make a huge difference. And as we just mentioned earlier, we can measure the functional changes in the lymphatic system using lymphoscinograms and indocyanine and green. And what happens when there's a functional problem is that there are changes in the levels of fluids in a lymphatic territory or a part of a limb or the whole limb or a breast tissue or whatever. As lymphedema progresses, it becomes fatty and fibrous-y, and it gets more and more difficult to manage and becomes more problematic. Anyway, all of these measured changes in fluids, fats, and fibers result in a classification resulting in various stages of lymphedema. Don't have to sweat them too much, but just remember there are. And in assessing lymphoedemas, there are all sorts of different ways of assessing it. And one of the ways is just measuring it simply with a tape measure and boards and all that sort of stuff. And you can see this is quite a tedious event. And there's a problem with this, that when you do this, if we're doing it over time, the limb volume can stay the same. The total limb volume can stay the same because it's made up of fluids, fats, and muscles. And if I just go back one slide, you can see that those three components can change. And what I want you to note is that you can see as time goes on, the limb might stay the same in terms of total volume as indicated by circumference and volume calculations, but there might be a weight gain and there might be muscle atrophy, or there might be an increase in fluid. So, you know, just measuring a limb with tape measures is not good enough over the long term. So that was my first very important point. For that reason, we've got all these other technologies like the basic pitting test. It's so old and in a way quite beneficial. And you push your finger into a given lymphatic territory or a part like the top of the foot or the top of the hand, and you see if there's an indent there. If there is, fluids are present because they're moved out by the pressure. There's another test, a basic test for fibrosis. And the fibrosis basically happens in the tissues. As lymphedema progresses, fibrosis occurs. And what happens there, the tissues become harder to move, it's harder for the lymph to go away, and we get problems. And this is a test for fibrosis is what's called the stemmer sign. And that's the inability to pick up a fold of skin. And very, very basic, but interesting, and it works. All right, now we've got other ways of measuring fluids. I'll just go into this one now. We've got other fairly fancy ways of measuring fluid called bioimpedance spectroscopy, as you heard a little bit earlier. These are pretty good techniques. The machines you see in front of you are able to measure whole body or segmental changes in fluids and indicate some other changes as well. We've also got some equipment which can measure fluid changes at a specific site using what's called tissue dielectric constants. So you can plonk these on the arm or on the leg on a particular site and see what sort of fluid's there, and in this case, at an indicated depth. So the other thing is we can also do the same for measuring site-specific buildup of fibrous tissue. And here you can see here we can measure the fibre in that territory or in this territory or in this territory or wherever we want, and we have to measure it in different territories because different territories progress or may progress at different rate in terms of fibre and fluid changes and build-up. So here you see some examples of those tools. You see here a very basic tonometer, which we helped develop way back in the very early 70s. This is the first one. So simple, so basic. And then it developed into an electronic indurometer and a few other fancy things like a fibrinometer. So there are quite a lot of tools that can measure tissue fibrosis and its progression and its change. We can also measure something called viscoelasticity in the tissues. That's the elasticity, whether it's lost or whether it's present or not. That's the tissue recoil, if you like. And that's an important indication of how the tissues are changing. We can also measure the fragility or the vascular stability or whatever you like of the tissues. This is really important in the case of a condition called lymphoedema, and it's estimated about 1 in 10 women may suffer from this problem. So that's also a measurement possibility that we have. There are other more fancy techniques of measuring fibrosis with ultrasound, as you may be aware or you may be able to look at, the Clarius and the Philips Lumify, which actually can tell us what's going on in the deep fascia, deeper down in the tissues, okay, what's going on in terms of fibrosis and fibrotic induration. Nice bits of equipment, but they're a little bit complicated for an individual to use. So like I said, we can detect tissue composition using tonometer, the indurometer, the fibrinometers and stuff like that. We can use them in any given territory. Now, let's get to the other side of the fence. That is, the things we use, the main way in which we control lymphedema is by bandaging, garments, wraps. They're the mainstay of lymphedema treatment and management. And we do have some fibers which can respond to stretch and some which can respond to temperature and indicate what's going on. They are sometimes built into some of these garments, except that era has sort of just dissipated a little bit lately, sadly. But what's most important with lymphedema is getting the pressure right and getting a pressure gradient. If you don't have the right pressure and you don't have a pressure gradient, you're in trouble because the lymphedema may be made worse by the very thing that's meant to help it. So there's all sorts of pressure censoring strips available and around the traps. And here's one with 30 different sensors in it. You can see what's going on there. Here's another one that was developed by Luke Parkinson, which has just got 5 pressure point sensors and can tell the patient and the practitioners what's going on with the pressure and the pressure gradient. However, here's what's a big issue in pressure measurements, and that is that the pressure delivered at a given point in the tissues is dependent on the curvature of the limb. I won't bore you about it, but generally say greater surface curvature means higher pressure delivered on the vessels under that surface. So we may deliver the wrong pressure to the wrong area and get a poor result. The other thing that's around is telehealth and a whole piles of different apps. There's one called LymphoTrack, which is particularly useful, but it's not totally integrated with any other measurement abilities and the like. It's got some issues and problems, but it's a brilliant step in the right direction. There's also a range of online programs, Help Online, an Australian-based program, and as Liz and Debbie were saying, many other programs of information for patients, particularly through the LAA. However, what we've got is this last slide, and Eric's probably getting a bit nervous on me because I talk forever. Now, the issues that we're all facing at the moment is as follows. We have a plethora of different types, shapes, and size of equipment, and some are cumbersome to use. Some are very difficult to use for patients. Some are very difficult even to be used by a therapist. Also, basically, we've got some good stuff out there, but we can do much better in terms of the integration of our technologies, the way in which they communicate with each other, and how that can benefit the therapists in terms of information, agglomerated information, and how they can benefit patients with respect to being aware of how their tissues are changing. And of course, as we mentioned, if we can prevent cellulitis, we're going to get a better health outcome for those, especially in rural and remote areas, as well as those in the cities. So, in some of the instances of equipment that's around, there's some reasonable technological use, but we're way, way behind other areas. The IT, I believe, is there. The AI is capable of putting an enormous amount of input into our area, but there's no integration, there's no cross-communication. And I want to say that we in Australia here have got an absolute chance to lead in all of this. I can see what's going on around the rest of the world, but we've got a chance to really make a difference. And here's our opportunity. So that's my last slide. Thank you.
Neil, thanks so much. What a brilliant place to end off. And a great opening to our workshop session as well. Our last speaker is Associate Professor Ramin Shayan, who is one of the leading experts, microsurgical experts and clinicians trying to treat lymphedema. And Ramin, it was your passion that sort of got us all started on this particular ACMD challenge journey, and I'm very pleased to hand over to you to tell us something about the surgical management techniques which you use.
Well, thank you very much, Erol, and thank you to the three previous speakers for this amazing summary of their respective perspectives. It's a pretty lonely place over the last couple of decades that I've been involved with lymphedema, and you see the same old people turning up to the meetings and presenting year after year, and it's great to see that there's now a critical mass and a multidisciplinary interest that we can all harness and work together to solve this difficult problem. My practice is both in private and public hospitals, the institutions you can see, with a research practice at the O'Brien Institute Department of SVI, and I would spend about 80% of my clinical time researching and operating on patients with lymphedema, and probably 80 to 90% of my research time as well. It's a very, very difficult problem indeed. And it's one of those things that we need to get better at. If we're going to help these patients survive their cancers, we need to improve their quality of life. I'm going to talk to you a bit about the biology, the diagnosis and the practice of surgical treatment of lymphedema. And interestingly, this entire field was founded in this very institution that I'm privileged to now run. Bernard O'Brien discovered or described in the 70s the treatments for lymphatic venous anastomosis, lymph node transfer and liposuction, and in 1990 produced his long-term results of his series of 114 patients. The institute that now inhabits the O'Brien name is very different. We've now, of course, merged into St Vincent's Institute, which has given us a lot more firepower and critical mass. But within our institute, we have a lymphatic and regenerative lab and an adipose tissue engineering lab, which very much go hand in glove in terms of the technologies we use and some of the research. And as Neil pointed out, lymphedema and lipedema are intimately related, and so our research areas speak to one another very, very eloquently. We use a lot of gene and molecular mechanisms for doing our research, animal models and disease models. The key is really where I started in this field, which was my PhD in 2003 in lymphatic vessel subtypes in biology and anatomy. And you can see here the capillary has the lymphatic initial or capillary lymphatic vessels in the superficial dermis, and the pre-collecting vessels in the deeper part of the dermis funneling down in a unidirectional fashion as guided by valves into the subcutaneous space where the collecting lymphatics are housed and have not only valves but also independently pumping pacemaker cells that coordinate the muscle pumping activity of the lymphatics. A very sophisticated organ, and as we've said already today, very much underrated in disease. And more recently, of course, it's been shown the lymphatics reside in the CNS, and really clinicians, when we talk about it, we're talking about the collecting lymphatics in terms of the function and the pathology that we've studied for many years. Happily, since the 90s, we've been able to look with molecular therapies and investigation techniques into the scientific side of the behaviour and biology and genetics of the other types of lymphatics in disease. And of course, we know lymphatics best from their role in cancer, from spreading the cancer from the tumour to nodes and beyond. And the scientists and the science field has really looked in some of the molecular mechanisms in those steps as well, so teasing out the role of the lymphatic structure. So during this journey from PhD to clinical practice, I'm closing in on about 500 of these lymphatic venous anastomoses. And this might seem not like a huge number in 10 years, but in fact, the work that goes around it and coordinating with all of the colleagues in various disciplines is very time consuming indeed. And it's actually a small percentage of the patients we see. Most people I don't operate on. So what does lymphedema mean to me? It's essentially first working out which step of this hierarchy, where in that hierarchy of the lymphatic vessels is the blockage and how can we circumvent it? What stage of lymphedema are they at, from the stages of being reversible, a mild, moderate through to severe? And in a paper we published in 2021, looking at the quality of life outcomes across the different types of lymphatic surgery, we found that of the published articles, there was certainly some reported benefit in ablative or physiological interventions with an improved quality of life over 6 to 12 months. However, the key thing was that there was no clear indicators of which choice was best, and it needed an experienced clinician and a multidisciplinary team to make those sort of decisions. Importantly, I think it's important to remember Bernard O'Brien felt very much that it was paramount you had every part of the treatment algorithm in your kit bag if you were going to treat patients surgically. It wasn't a one-size-fits-all, and I think that's one thing that's critical that we maintain that. As we've said, primary versus secondary lymphedema. Most of the work in lymphatic surgery has been done in secondary lymphedema, particularly in the cancer space. And in terms of primary, the classifications have ranged from radiological to clinical, time of presentation, and more recently, the availability of genetic models as well. And we were lucky enough during my PhD to be a part of the paper by Francois et al. From Koopman Lab in IMB, Queensland, which described a SOX18, the master switch of lymphatic development. And so we found we could describe and quantify the lymphatic deformity that led to the lymphedema, and also the human correlate in pathology has been one part of the tapestry that has been put together in this seminal paper by Mortimer and his colleagues in terms of trying to characterize and map out which genetic defects there are. You can see it's a complicated slide. There are a lot of interrelating defects. But when I see patients with primary lymphedema, I try and first look at the genetics and see where they fit, because it gives a clue as to what the pathophysiology is and therefore what the most appropriate treatment is. And some people you just can't find a gene defect, but there are those that you definitely can. And the exciting part for me is, for example, allotting one of these gene defects into the pathology, you can then inform the patient as to what the problems are. This is a patient on the far right who has a defect with his valves that leads to his lymphedema. And in his 17-year-old son, who is clinically not presenting with lymphedema, one could find the same valve defect, presenting the opportunity to enable us to treat him early. So the staging now, we've sort of added the staging with imaging into Sign and Green studies, which have been mentioned by the previous speakers. And so now we can correlate that degree of fibrosis versus fluid, that ratio, which is critical, the lymphatic pathways and the damage done to them with the clinical presentation. And it's critical to understand that lymphatic surgery is not a cure. It really irritates you when people call it a cure. At best, you can get the patients to be in remission, but it's not curative. And it just takes one infection, one loss of compression or a plane flight to get you back to where you were. It is an adjunct to some patients who are appropriately selected, who have an appropriate ratio of fibrous versus fatty fluid. So the key is what level is the defect? I use MRI and ICG, as we've discussed. You can have different conditions disguised in there, lipedema and other things. It's important to quantify these. Really, I want to understand the defect and the stage of the disease, and I prefer our lymphangiogram to scintigraphy, as you can see from the picture on the right, which is the same patient for the two techniques. I will essentially try and stage and understand the ratio where their progression is from fluid to fibrous, because, of course, if you're doing lymphatic microsurgery to map and then operate on the lymphatics, that there has to be a lot of fluid. Otherwise, you're not going to affect it with that technology. And infection, of course, pushes the patients along the spectrum. That's why it's critical. So with those technologies, I will try and find the lymphatic defect, understand it in terms of the subtypes affected, the stage of disease, map them in a surgical roadmap, using combined modalities of MRI, ICG, as well as patent blue dye in the day. I'll try and understand where the lymphatic defect becomes apparent. You can see in this image, there's a stenosis there. And then after this, there is a loss of control with leakage up into the dermis. And so I'll go in at one of those points, find the lymphatic vessels here marked in blue, and under the microscope, we'll transfer them into the veins, hopefully providing an element of bypass. Doing measurements, so you can see that you can get, if you're talking 0.03 mils per minute, you can get approximately 85 mils a day for a good anastomotic connection in the lymphatic vessel. That's the join marked in a circle between the lymphatics and the veins with microsutures of about 11.0 caliber. That's the venous valve, which has been critical to plan to have above the anastomosis to stop reflux into the lymphatics and thus sabotaging your operation. Lymph node transfer I do infrequently because of the fact that one can't guarantee that they're not going to provide the donor site with its own set of problems for the patient. The lymph nodes you took to transfer can then create lymphedema in the limb, and that would not put you on the top of the Christmas card list. So I typically use the supraclavicular donor site here up above the clavicle and the neck. But in appropriately selected patients at appropriate stage 0 to 1 in particular, you can get a lasting remission that definitely provides the patients with beneficial quality of life changes and functional changes that they can use to get on with life, provided they have that basic fundamental understanding and education, which we spoke about earlier, that this is a disease that is in remission. It's not a cure. It's at best a temporary improvement. And so they need to have a strong relationship, an ongoing relationship with their therapist and with the other clinicians involved in their care. Some patients, select patients where that fibrosis to fluid ratio is favourable, you can actually get a reasonable result. But the thing is that you have to let them understand that this microanastomosis using fluid dynamics or change the fluid dynamics can never possibly get rid of that scarred fibrosed tissue. So the best way to prevent that is by stopping it happening through MLD and compression and the rest of the things we've spoken about. Rarely in stage 3 disease, and sometimes it's a matter of improving that, breaking that cellulitis to fibrosis cycle is the key outcome we can achieve for these patients. But again, the same principles: find the lymphatic defect, understand it. Are you actually doing something that's achievable and realistic for the patient to get an improvement? And I think the exciting part for me is a combination of therapies and the areas of primary lymphedema that we talked about. You can get some select patients to improve, but you do have to know the genetics, what genetics are driving their defect, how far progressed their defect is, and whether it's a reversible change that's taken place in their pathophysiology. So when I analyse my patients, lastly, I make sure that the analysis is therapist-led, so it's not me biasing it. The other I think, very sensitive thing that we didn't talk about is patient symptoms are very indicative of how much fluid is there. I do a questionnaire which has objective and subjective components, and then I try and do a 12-month review if it's a microsurgical case with ICG to make sure the LVA is patent. So in closing, I think it's really important to understand that surgery is not magic. It is a step in the process between the pre and the post-op, and the real research, the molecular therapies will be what the answer is if there is to be a cure. I'd also like to thank our generous donors. It will incense everybody here to know that when we put in NHMRC grants, the replies have been great project, great ideas and team. It's just this is no longer a clinical problem, and I think all of us on this call beg to differ significantly. You can always be in touch with us at the O'Brien Institute Department of SVI for further information, ideas, or for coming in and having a visit. Thank you very much to Erol once again and the whole ACMD and all the previous speakers.
Brilliant. Thanks, Ramin. And that was a marvellous explanation of how far we currently can go with surgical interventions. I'll ask all the speakers to turn on their cameras now, because we have got some questions that have been popping up in the Q&A box. And maybe if I can just pick one, something that you mentioned, Neil, was an opportunity to better integrate IT AI. And I guess that ties in with some of the previous comments that this is an underdiagnosed and we don't have enough data, not only to lobby, which is what I think Debbie was saying, but maybe even to research the field. Could you explain what you mean by that integration, Neil?
Yes, it's about there's each of the techniques I was talking about for measurement of tissue change, for the measurement of fibrosis and these sort of things, what they are used at the moment as just as a measurement, okay, to see where things are in a static situation, not how things are progressing. and not where that progression links to a significant, what is regarded as a significant change in the tissue composition, which may indicate a worsening or an improvement of the lymphedema. And that's where we need to have artificial intelligence algorithms coming in and saying, yeah, this represents a significant improvement on the basis of our knowledge. And we can improve what we mean by significant improvement by doing more research in this area and looking at, as you know, the whole picture of the limb, not just a particular site like we sometimes look at and concentrate on. Fair enough, because we can't measure everything, but it's all about integrative use of the information, the IT, the equipment, the type of equipment that we use, its structure, its functionalities, and the outcomes that we know we're looking for, and an awareness of the benefits of some of those outcomes early on when we know things are going in the right direction or when they're going in the wrong direction. Let's get in and intervene quick, because you don't often do it quick enough. And
we often get feedback from the clinics who are treating lymphedema, and we ask them, what are your bottlenecks? The first thing they tell us is funding. And then we say, all right, yeah. And if you got more money, what would you do with that? The time taken and the skill that is required to collect those measurements is long and hard won. Is it feasible to get meaningful home-based measurements, for example, that could help with that progression? Maybe Neil, and then hand over to Liz and Debbie.
A simple answer, yes, but we can do better. The reason why these measurements are important is for the targeting and sequencing of treatment to optimize the outcome. So Liz and Deb can talk about all those sort of things too, better than I.
I think certainly there's a couple of things here. One, patients can definitely be involved in monitoring and assessing their own limbs. There's lots of evidence that patients can undertake circumference measurements. They understand how their tissues are feeling, whether they're changing in their thickness and their pitting. They obviously understand how they're feeling and how the tissues are changing subjectively to themselves as well, better than obviously clinicians can. So 100% patients can and should be involved with their monitoring of changes of their lymphedema. And then I think we're coming back to that AI and IT integration. We've talked about the fact that we do a lot of assessment for lymphedema because of the complexity and the difficulties in trying to unpick all of the different aspects of it. And I think that's where a learning healthcare system would be able to integrate that data across all of the visits to start to put together what is important in making those decisions better than individual clinicians and research projects can. So I think there's a great place for large data set analysis using some AI technology to really start to understand how these things all work together.
Yeah, and I'll go back to my emphasis of my circumferential measurement and volume change calculation from that over time, how inaccurate that on its own can be for us, because the limb can become, you can have muscle atrophy, and you can have a big increase in fluid and a similar increase in similar size of fats, and the limb's not changing. Then you can go the other way around, the limb's not changing, but there's all sorts of compositional changes going on. And that's where the integration of simple things that the patients can do with IT and AI and stuff could make a better outcome, make that measurement more valuable for therapists and for the patient.
Debbie, a question popped up in the Q&A about cost and how expensive it is, and I see you've put an answer up that it can cost $2,000 to $3,000 a year for garments, which
it's really variable, and I tried to write an essay in response, and that's it, because someone that has mild lymphedema might be spending only $150 on their garments. Someone with severe, it's some people need almost full body, and when you're looking at those, when they need to be actually made to the exact, couple of millimeters to provide, that's obviously a really costly process, and it does cost several $100s per, and I'm lucky I put up the cost of mine. I'm not actually sure if everyone can see those answers if I put it up, or that was so I think it does really add up, and what the question was also based around what funding there is, so whether there's money back from health insurance providers. And again, that's really variable, but probably the average one would give about 15% back on a garment. And there's quite strict protocols on what criteria people have to meet. They kind of make their own rules sometimes. Yeah.
And does it have to be very specific? How accurately does the compression garment have to match the patient? And I assume, costs of scale to bring down prices mean that you'd have a standard garment. How does that work?
Yeah. I mean, if you've got a standard garment, when you look at those pictures of limbs and you look at some of them with the shapes and the folds where they are, there's no way a standard garment is more what you'd buy for a flight sock. And really you're looking at a model's leg or arm, and that's just not what lymphedema is. So the standard off-the-shelf ones will tend to be more helpful in someone who wants to wear a garment to prevent swelling after surgery, where they've already got a standard size limb. But even then, if those aren't fitted properly, as Neil alluded to, you can actually send fluid the wrong way. And people have been known to go, I really don't want to get lymphedema, so I'll put on a sleeve, get on a plane, and hopefully I won't get lymphedema. And actually the opposite happens because it wasn't fitted properly for them. So it is crucial at the current technology that we have that it is fitted properly, because I know that when I've had it, I remember one, millimeters, the number got reversed or something happened and it was a few millimeters out, but that was the difference between my toe feeling like it was being cut off and having to rip off the garments because I was actually damaging my circulation. So there's not that much room for error when it comes to some of these garments. Yep.
Yep. Dealing with the lymphatic system, the pressure of the gradient and the pressure that's applied by the bandage and having a pressure gradient are absolutely essential. And we've always got to ask the question, what are we compressing under the limb? Are we compressing the lymphatics wrongly? Are we compressing the venous drainage, the veins, draining the limb of blood? We've got to be really careful and ask ourselves those questions. By what are the benefits? What are the negatives of compression if it's given wrongly? And that's why many garments go back, because they're not appropriate. Many patients have some bad outcomes because they're not appropriate.
Yeah.
Well, Erol, you can see limbs tourniqueted at an extreme case, and I've had to amputate limbs that have gotten so much compression that they become tourniqueted in the hand or the leg becomes out of control. So it can be extreme. Yeah, I was just going to add, sorry, there are jurisdictional variations. Some of the states that I get patients from for surgery have a far more generous scheme than others. There's actually some state health service based help.
Yeah.
In some places, not in Victoria.
Yeah.
Ramin, just a last question I want to put to you has come from the Q&A. Do you think there's a possibility to create a technology that artificially replaces drainage function? I guess one of the things that strikes one from the talk you gave is that if you're doing a transplantation as a technique, you could potentially be moving the problem to somewhere else. What about the possibility of new materials and artificial systems?
It's a great question. I think one of the things to realise is that also the limitation is that you're transferring the lymphatics into the veins. And if I had a longer forum, I'd go into some detail about what the veins need to be like. Unfortunately, there are certain genetic problems where we're familiar with varicose veins. If you've got a varicose vein, you won't be able to transfer a lymphatic into it because the higher pressure system will just reflux back into the lymphatics, and it's a pointless exercise. So there are limitations in each patient. The other thing about a foreign body, of course, is, as we've been saying, we've all seen clinically, the patients with lymphedema are very susceptible to infection. So you can imagine the best way to get an infection is to put a foreign body through the skin into a lymphedema area where effectively the immune system it's a sort of a no-go zone or an internet black spot for the immune system in the lymphedema limb. Those are the limitations of creating a device that is implantable into these areas. I think we've touched on the fact that fibrosis is a big problem in these limbs in particular. And so the fibrosis, of course, has a disproportionate negative effect, as does infection. And that cycle that we spoke about of the fibrosis and infection it makes this a hard area in which to operate, as in to work, not so much operate surgically. But certainly surgery is a bad solution for most lymphedema patients who've got that fibrosis cascade or the infection pathway that started. And I think that limitation does extend to devices and technologies. Now, that's part of the innovation that's needed, is a clever way to circumvent those problems.
Thanks so much, and thanks to all of our speakers for a great introduction to the issues around lymphedema. As I said, this is the first step of our process. We will have a focused workshop on a couple of these issues later on, but clearly in a 1-hour workshop, we're never going to solve such a huge and big problem as this. What's important to us at ACMD is to start the conversation with as many different members of the community and different skills as possible, so that we can address some of these problems in a different way than what's been met before. And to do that, we are constructing a new building. For those who are resident in Melbourne, you'll see the corner of Victoria Parade and Nicholson Street is a big hole in the ground at the moment. And at the end of 2 years, we hope to have this new facility up and running. We want it to become an area where we can bring clinicians, entrepreneurs, engineers, scientists, members of the public, patients together to discuss important health problems just like this, but of course also to try to come up with some solutions. Just a quick intro of our timelines. 2025 is when we think we'll have our new building up and operational. Completion is currently slated for November 24. So we're in the part of the program looking at ACMD Challenge. And next year we'll be pulling together project teams to apply for funding, because that always takes a while, to start to have a look at some of these big problem areas. The other kind of programs that we'll have up at ACMD, this is ACMD Challenge. ACMD Advise is how to, it brings together experts to help you create research projects which are translatable, which can get into clinical practice, which can become commercially viable. And ACMD Engine is where we roll up our sleeves and become involved in some of these translation projects. ACMD Link is a bi-monthly webinar where we're just joining clinicians, researchers, technologists, getting the community warmed up. If you're interested in any of those, please scan this QR code. It'll take you straight to some forms that you can fill in. Michelle or I or some of our team will be in touch very quickly, and we'll love to keep this conversation going. So thank you so much for joining us for this seminar series. Again, thanks to our speakers. We look forward to the workshops for those who are participating in person. If you have any other big grand challenges, please send them in. Very happy to have a look. And if you do have time, please hang on for a few moments and fill in the survey at the end. Thanks very much indeed for joining us.
Yeah, and thanks, Ramin, for starting it all. Good on you.
No problem. Thanks for coming. Cheers.